Good afternoon. Thank you for coming to this session on central nervous system complications of HIV. This is a poster discussion session. My name's Alan Winston. I'm from London in the UK. I'm hoping to be joined by my co-chair, Paola Cinque, from Milan in Italy. So she may come in any second. We have 7 presentations. They're 5-minute presentations each. What I would propose is that we go through the presentations and we save the questions from the end for the end, okay? So I'd like to invite our first presenter, who is Jonathan Chan from the US. And Jonathan is a medical student from Duke University of Medicine. He's received a master's in public health from Chapel Hill, and he's here to present to us today on immune activation and depression in rural Ugandans. Thank you, Jonathan.
Thank you. Is this on? Okay. It's my pleasure to be here, and on behalf of my co-authors, it's my honor to present our study, Persistent Immune Activation and Depression Among Ugandans Initiating Antiretroviral Therapy. I'd like to take a moment to acknowledge persons with HIV who contributed to this research. Numerous studies have demonstrated that chronic inflammation, even after ART-mediated viral suppression, is associated with numerous comorbidities, including cardiovascular disease, neurocognitive impairment, frailty, osteoporosis, etc., and as well as all-cause mortality. However, the relationship between inflammation and neuropsychiatric outcomes like depression are less clear. We use data from a closed prospective observational cohort study, which enrolled Ugandan adults initiating antiretroviral therapy from 2005 to 2013. We observed these participants 3 to 4 times a year for a minimum follow-up period of 2 years. We were interested in 5 inflammatory markers: a pro-inflammatory cytokine, interleukin-6, marker of coagulative processes, D-dimer, 2 markers of macrophage activation, soluble CD14 and soluble CD163, as well as a marker of tryptophan metabolism, the kynurenine-tryptophan ratio. Our exposure specifically was the difference between log 10 levels at pre-ART baseline and 6 months since ART initiation. We additionally structured the exposure into quartiles to flexibly model exposure, with the smallest decrease in biomarker as the referent. Our outcome was depressive symptom severity as measured by the validated Hopkins Symptoms Checklist score during visits during the first 2 years of ART use. We coded the outcome in 2 ways. One is a continuous score, which ranged from 1 to 4, as well as a binary probable depression outcome defined as a score greater than 1.75. It's a validated cutoff that has been used in previous studies. We used generalized estimating equation regression models to account for repeated measures and adjusted for numerous demographic and clinical characteristics, most notably BMI, smoking, CD4 count, as well as viral load suppression. For a continuous outcome of depressive symptom score, we found, just to orient you, this is the 2nd quartile, 3rd quartile, 4th quartile, with higher quartiles representing larger decreases in biomarker within the 6-month time period. For soluble CD14 and KT ratio, we found significant associations with larger decreases in biomarker predicting lower depressive symptom scores as compared to the 1st quartile. For the other 3 biomarkers, we did not find significant relationships. In repeating analyses for soluble CD14 and KT ratio, additionally adjusting for the other biomarker, we found that the relationships were similar, albeit a little attenuated. For our second outcome, which is the binary probable depression outcome, we found similar patterns, with quartiles representing larger decreases in biomarker, having a lower probability of depression at each visit as compared to smaller decreases in biomarker. Again, in repeated analyses, adjusting for each other, soluble CD14 and KT ratio associations were qualitatively similar. And just to give an estimate of the magnitude effect, we're looking at, for KT ratio, about an absolute probability reduction of about 7% of the 4th quartile compared to the 1st. So in conclusion, this study shows that greater decreases in inflammatory biomarkers, specifically insoluble CD14 and kynurenum tryptophan ratio, were associated with lower future depressive symptoms after ART initiation up to 2 years since ART initiation. We suggest that additional measures beyond suppressive ART may be necessary to reduce mental health disturbances and promote mental health in persons living with HIV, and specifically measures that target macrophage activation, as evidenced by the soluble CD14 results, and measures that target tryptophan metabolism may also be effective. Thank you.
So, Jonathan, thank you very much for a very nice presentation and for sticking to time, and I'm sure we'll come back to many questions. So the next presentation is from Jean van Wyk, who is, and Jean obtained his medical degree from South Africa and has since completed specialist training in pharmaceutical medicine in the UK and currently is the Global Medical Affairs Director with ViiV Healthcare. So thank you, Jean.
Thank you. Good afternoon, and thank you for the opportunity to present these data on behalf of my co-authors as well as ViiV Healthcare, for which we are all employees. So just as a bit of background, in the phase 3 clinical development program for Dolutegravir, the rates of neuropsychiatric adverse events have been shown to be low and comparable to the other regimens given in these trials, and also rarely led to treatment discontinuations, typically less than 1% across any of these studies. However, recently in observational data and cohort studies that's been presented, it has been shown that the rates of treatment discontinuation due to neuropsychiatric events with Dolutegravir is higher than what has been reported in the clinical trials. And across the 24 studies that we were able to review, these rates ranged from 0 to about 8.3%, with the largest 3 cohorts showing discontinuation rates of around 2.3%. And some of these cohorts have also looked at risk factors, and the risk factors that's been shown to be associated with neuropsychiatric events were previous psychiatric history in most cases, but also abacavir co-administration. So the aim of our study was to do a meta-analysis and to explore potential factors associated with neuropsychiatric adverse events for Dolutegravir-treated patients. And we used our phase 3 and 3B database to do this. We were able to include 1,672 participants on Dolutegravir and 1,681 on non-Dolutegravir containing regimens. We had 2 analyses of interest, firstly looking at Dolutegravir versus non-Dolutegravir therapies, and secondly Dolutegravir plus abacavir versus Dolutegravir plus non-abacavir-based therapies. And the neuropsychiatric adverse events that were included were insomnia, anxiety, depression, suicidality, nightmares or abnormal dreams, as well as headache. So in the main analysis, which was a patient-level analysis, and that was our primary analysis, we found that there were no difference in the rates of neuropsychiatric adverse events between Dolutegravir and non-Dolutegravir-based regimens, and these rates were 5.26 for the Dolutegravir-treated patients and 5.21 for the non-Dolutegravir-treated patients per 1,000 patient years. And similarly, there were also no differences in the rates for Dolutegravir plus abacavir versus Dolutegravir plus non-abacavir-treated patients. Now, looking at the patient-level analysis, again, this was our primary analysis for the variables associated with neuropsychiatric adverse events. We saw in the Dolutegravir versus non-Dolutegravir group that age, previous psychiatric history, as well as region were associated variables. And in the Dolutegravir plus abacavir analysis, we saw HIV-1 RNA, previous psychiatric history, and region as associated variables. We also performed a secondary event-level analysis, and you can see the results there on the right. So across these 4 different analyses, the variables that we found to be consistently associated with neuropsychiatric events were previous psychiatric history and region, with North America having higher rates compared to the rest of the world. We also looked at exploring whether insomnia, which is one of the more frequently reported adverse events, was associated with any subsequent neuropsychiatric events, but we could not find any evidence for that. So in conclusion, in this meta-analysis of 5 clinical trials, we did not find that there were an increased rate of neuropsychiatric adverse events for dolutegravir versus non-dolutegravir treated patients. We found that previous psychiatric and region were associated across the different analyses, but not concomitant abacavir use, or as I already mentioned, dolutegravir use itself. And also insomnia in the exploratory analysis was not found to be a precursor to the development of neuropsychiatric adverse events. So thank you, and I invite you to come and look at the poster for more details.
Thank you very much, John. So we're moving on to a couple of presentations now looking at central nervous system aspects of children with HIV. And the first presentation is from Emmanuel Nwosu. And Emmanuel's a PhD student in Cape Town with his research focusing on magnetic resonance imaging in children with HIV. So thank you.
Good day, ladies and gentlemen. I'm presenting with Farai on a set of studies that have been carried out in a neuroimaging follow-up study. And we are going to be presenting the findings in the children from the SHARE clinical trial. Farai will take up some of the slides the moment I finish presenting my key finding. But then I want to thank the entire team that is involved in the whole research work of the neuroimaging follow-up study on SHARE trial. Quite a lot of them have contributed a lot in the result that we are presenting, and even with the slides that we are presenting this afternoon. Some of them are seated here in the audience, from University of Cape Town, Stellenbosch University, and Massachusetts University, Massachusetts General Hospital, United States. Find some time, because we are going to be very brief with this presentation, so find some time to visit our posters. Myself and Farai's poster is just right behind, so you can get to understand more about it. And then the other 2 posters of our colleague that is working in the same research lab is in the poster exhibition center, so you can get to know more about what we are working on. Okay. Just to quickly walk you through our study, the landmark SHARE clinical trial conducted in South Africa between 2005 and 2011 changed global ART guideline towards early therapy for all, especially vertically infected children. So SHARE clinical trial is a very popular study, but then it changed a whole lot of things. Subsequently, we've gone ahead to follow up the children that are involved in this study. And the SHARE cohort, we have matched with the uninfected control from an interlinking vaccine trial of similar age and from the same community, who are either exposed or unexposed to HIV, but are all uninfected. Then our HIV children in this neuroimaging follow-up study are split into children on interrupted ART and those on continuous ART who has been followed with multimodal longitudinal neuroimaging methods at age 5, 7, 9, and 11-year-old. The result or the findings that we'll be presenting this afternoon is I'll be presenting the HIV structural image, the MRI structural image results that we've got so far on the effect of interruption at age 5. While Farai will be talking you through the findings that we have found with the DTI image, imaging modality at age 9, looking at the effect of HIV infection and ART exposure at age 9 years. So talking about the result that came out from the age 5 brain morphometry and cortical development study, we found localized cortical thinning in the video that you're looking at on the left. Looking at the left video is the result of the cortical thinning that was observed due to the effect of ART interruption. And the video that you are looking at on the right is the video of the result that showed the regional cortical folding reduction. In both videos, the regions that are in blue are the regions where the effect of cortical, the ART interruption led to either cortical thinning or cortical folding reduction. For the cortical thinning, especially in the left lateral occipital region, there was reduction in cortical thickness. And for the result on the cortical folding, especially in the bilateral superior parietal region, there was considerable cortical folding reduction. So this made us to come to the conclusion that ART interruption alters brain morphometry at age 5 years. And at the moment, there is an ongoing neurodevelopmental test going on to establish whether these observed cortical developmental changes that has been observed in these children would have any long-term effect on their brain development. Now I'm going to hand over to Farai to talk us through the findings from the HIV infection and ART exposure, the effects that we observed at age 9. Farai.
Oh, thank you, Emmanuel. Good afternoon, ladies and gentlemen. It is an honor to stand before you to present our work. At 9 years, HIV-infected children had classes of lower fractional anisotropy and higher mean diffusivity compared to uninfected controls. These are measures that are related to axonal integrity and structural organization in white matter bundles, respectively. The green in these images show white matter tracts throughout the brain. Overlaid in blue on the left and red on the right are shown regions of white matter alterations within these tracts. The main tracts affected are the corticospinal tract, the inferior frontal occipital fasciculus, the inferior longitudinal fasciculus, and the anterior thalamic radiations. These are also seen at 5 and 7 years. Interestingly, a new finding in the corpus callosum, which was not present at 5 and 7 years, is seen. In the HIV-exposed uninfected children, we report lower MD in the corticospinal tract compared to unexposed children, which is consistent with our previous findings at age 7. At 9 years, lower mean diffusivity in the inferior frontal occipital fasciculus is also seen. Lower mean diffusivity is associated with organized white matter microstructure. These differences may possibly be an ART-related exposure effect. Differences were largely attributed to complications in myelination of axons in the developing brain. Thank you so much.
Thank you both so much. And I didn't get an opportunity to introduce Farai Maberi, who's also working in Cape Town. Thank you both. So we're moving on to another central nervous system comorbidity and stroke now. And it's a pleasure to invite Hulin Lin, who's a PhD student in China Medical University and is presenting on the incidence of stroke. Thank you.
Ladies and gentlemen, it's my honor to have this opportunity to present my research here. I come from Taiwan, and the topic is the incidence of stroke with HIV infection, a population-based study in Taiwan. Few studies evaluate whether people infected with human immunodeficiency virus are at an increased risk of stroke in Asian population.
Let's go into your presentation.
Okay. Okay. And whether the risk of stroke increase over time remains unknown. And this study investigates the incidence of stroke in people with HIV infection compared with general population in Taiwan. We're using the claims data of Universal Health Insurance Program. We identified 5,961 HIV/AIDS patients without previous stroke from 1998 to 2005 and follow them up until the end of 2011. Standardized incidence ratio were calculated to compare the incidence of overall ischemic and hemorrhagic stroke in HIV/AIDS patients and compare with the general population by age, sex, and duration of follow-up. And this is the flow chart of this study. 23 million people enrolled in Taiwan's National Health Insurance Program. We include 6,078 HIV-infected or AIDS patients registered for catastrophic illness for the first time from 1998 to 2005, and 117 patients excluded. And we enrolled 5,961 HIV infection or AIDS patients. We follow up them until the end of 2011. And finally, 103 patients developed stroke, involved 59 ischemic stroke, 29 hemorrhagic stroke, and 15 with undetermined stroke. And table 1 is the characteristics of these patients we included. And we can find the result that HIV/AIDS patients had a higher risk of developing overall stroke, ischemic stroke, and hemorrhagic stroke. The risk remained consistently and significantly higher among all age and sex groups. In all patients and each of age stratification, the SIR was the highest within 1 year. After diagnosis of HIV/AIDS established for all patients, with all stroke, the SIR was 46.62, and ischemic stroke and hemorrhagic stroke, and the risk diminished over time, and no increased risk was observed after 8 years of follow-up. And our results show that the investigation of HIV infection as an independent risk factor of stroke incidence in different countries is worth noting. Our findings provide information for agent subjects that individuals with HIV/AIDS among different decades of age and sex an increased risk of ischemic and hemorrhagic stroke, and the greatest risk was observed within the first year after HIV/AIDS diagnosis. Thank you for your listening.
Thank you very much. So we're moving on. Unfortunately, Kevin Robertson can't be here. He was meant to have sent a replacement, so if anybody knows, please let me know. So we'll move on to the last presentation. It's Lizzie Cousin from Martinique, and Lizzie's been an HIV specialist since the 1990s, and we're going back to the earlier theme on antiretroviral toxicities. Thank you.
Mm-hmm. It's just too low. Yeah, I get it. Okay. Thank you. Good morning, everybody. I'm glad to be here today to present on behalf of my co-authors. I work on neuropsychiatric side effects in relation with integrase inhibitors in a large French perspective cohort. Our objective was to search in our cohort all the reasons for integrase inhibitors discontinuations in relation with the drug in the patient, in patients who started their first integrase inhibitor containing regimen since 2006. As you can see, we studied over 21,000 patients. You have a very, very brief description of the population here. Note that globally 28% were women, that there were many more antiretroviral naive patients in the Elvitegravir group than in the Dolutegravir group or Raltegravir group. Association with the Bacavir was non-existent in the Elvitegravir group due to single tablet regimen formulation, and some patients had in their past history already discontinued another antiretroviral regimen due to a neuropsychiatric adverse event. So discontinuations of the anti-integrase inhibitors are described here. As you can see, 12% of the Dolutegravir treated patients did discontinue their treatment, as did 20% of the Elvitegravir group and more than half of the Raltegravir group. Note that in the Raltegravir group, the main reason for discontinuation was simplification, of course. So neuropsychiatric side effects did occur in the patients in 2.7% of the dolutegravir treated ones, in 1.3% in the elvitegravir treated ones, and 1.7% in the raltegravir group. Virological failure was really rare, less than 1% in the dolutegravir group, 3.2% in the elvitegravir, and 7.8% in the raltegravir. In the adjusted analysis, we can see that neuropsychiatric adverse events were more frequently related to dolutegravir than to elvitegravir, to dolutegravir than to raltegravir. The gender association was not found in our study. It was not far, as you can see, but it was not significant. The patients who were already antiretroviral experienced and those who already had been stopping another regimen due to a neuropsychiatric side effect were more prone to have neuropsychiatric side effects while taking Integrase inhibitors. So in discussion, we found that both dolutegravir and elvitegravir are potent and well tolerated. Neuropsychiatric adverse events do exist. They're rare, but they do exist, and they may be really related with dolutegravir. We show differences in the patients at the time of prescription, and I would really ask you to go to see the poster because those populations in the three groups, three different drugs, were really different at the time of prescription. We could not find any association in our study with abacavir, and I'm glad my precedent, you didn't find any, so okay, it's good news. But we thought that we couldn't find any because as you saw, no patient taking elvitegravir also took abacavir, so we had a clear confusion in this discussion. The gender question, in my opinion, remains to be studied more. Of course, our study has limits. We may have classification bias in the reason for the treatment discontinuation, and we do not have therapeutic drug monitoring in this study. Finally, I would like to thank everybody, beginning by the patients in care in our centers, all the center staffs, doctors, but not only, for the quality of the data, my co-authors who are not here today for their contribution, Philippe for the statistics as usual, and you for your attention. Thank you.
Thank you very much. So, very clear presentations, and thank you again, everyone, for sticking to time. We've had several different themes: antiretroviral drug toxicity, comorbidities, stroke and depression, and children and neuroimaging. So, all the posters are open to questions now. I'll start with some questions while people are hopefully coming up to the microphones. So, regarding the two presentations on neuropsychiatric side effects with the integrase inhibitors, we keep seeing this, that in the cohort studies we see a signal, and in the phase 3 studies, when they're all put together, we don't see a signal, or we don't see such a strong signal. Any comments from the two of you on why you think this is? Is it a capturing issue in the phase 3 studies, or what's going on?
I think that you've mentioned it already, but probably there's two things to consider in my mind. Firstly, we have a cleaner population in the phase 3 trials. Certainly debilitating pre-existing conditions are excluded. So it could be possible that in a real-world cohort, in the real world, patients have a higher incidence of baseline disease, which could be unmasked by therapy. But secondly, and you also referenced it, there's also the potential for selection bias, especially with newer agents where something might not have been shown. And for example, from the OPERA cohort, we have seen that, especially when compared to efavirenz, patients are put onto dolutegravir that have higher baseline rates of pre-existing conditions. And from our data set and from the ones that I've reviewed, and I see from yours as well, pre-existing conditions remain the highest risk factor that we can identify.
Yes. I do agree with the selection population question because in studies the population is really selected. We work with all the patients in care in the center, so everybody, old, young, everybody. And the last thing is, in our cohort, we took everybody who started an integrase inhibitor containing regimen since 2006. That was to capture the Dolutegravir population. But we have to note that Dolutegravir has been used in France only since 2014, and it was at the beginning of 2016 that at the CROI the alert came in, and much of our patients started the treatment in 2016. So we cannot avoid to think that doctors were just on alert, and that at any signal bringing the patient seeing, I don't feel well, I don't sleep well, I feel tired, and so on, the doctor said, oh, alert, stop it. And we just collect this. So we may have, but we were, it was good news to show that we had 2.7% events. That was not really high. It was just like in the other cohorts, like in the Swiss cohort. So it's just like in the range of what has been described.
Okay.
CL, I've got a quick question for Jonathan and one for Hugh Lin. So Jonathan, interesting results. You adjusted for smoking and alcohol use. Did you have any opportunity to look at other recreational drugs, and could they potentially confound your association?
That's a great question. So we do have data for like IV drugs, crack, and things like that in our cohort. However, the prevalences for those, the baseline prevalences for those are very low. So there shouldn't be much confounding if there is confounding by those, just based on the low prevalence. It's a little different from, I guess, just to add on, it's Ugandan cohort is much different from American or a European Western cohort, where the rates of drug use are a lot lower.
Or at least the rates of reported drug use, I assume.
That's true, yeah.
And for Hugh Lin, the stroke association, it's really interesting that you found that very high rate in the first year after what you said was duration of infection, but I assume it's just time since diagnosis, given that it's at a population level. So the question is, do you think that is real? And if so, what is the biological rationale behind that? Because I'm not sure that I've seen other data suggesting the rate being very high in the first year and then dropping off. Or do you think it is, again, just confounding by whatever prompted the diagnosis of HIV, or some behavioural factor that actually got people into care and got people tested?
Okay, thank you for your question. In our study, we found that the highest risk of developing overall ischemic and hemorrhagic stroke was within the first year after diagnosis of HIV/AIDS patients. Across different age groups, the effect was more prominent in younger age groups and diminished by longer follow-up years. In Taiwan, some patients were diagnosed with HIV infection by routine screening incidentally. Approximately half newly diagnosed HIV infection patients have clinical AIDS or CD4 T lymphocytes count less than 200. According to the data from Center for Disease Control and Prevention, half of the individuals met the definition of AIDS less than a year after diagnosed with HIV infection. And our results reminded that late diagnosis of HIV patients were not uncommon. Yeah, because we include these groups, they are got the catastrophic illness of certificates of AIDS.
It's all driven by late diagnosis and low CD4 counts and immunosuppression.
Yeah.
Okay.
Thank you. If we maybe go round the room then, so can you everyone introduce themselves as well, please?
Okay, thank you. Pim Brouwers from the National Institute of Mental Health, and I have a question for Jonathan Chang. Obviously, as the Institute of Mental Health, we are very interested in tryptophan and its relation to serotonin pathway. And so the question was whether in your ART patient or the patients that are getting ART, do you have sufficient amount of variation that you can see whether specific ART agents are related with changes in the tryptophan metabolism and serotonin? Because there's been some suggestion that either dolutegravir or even efavirenz may have a specific an effect on that pathway.
That's a great question. Yeah, so in our cohort, I think about 70% are on efavirenz, and about 30% on nevirapine, and then the backbone's 3-GC-TDF for the most part. So nothing like with dolutegravir and protease inhibitors are generally very rare in our cohort. But that definitely could be a question that we would query in our cohort. Yeah.
So you can actually look at efavirenz versus non-efavirenz?
Yeah, efavirenz versus nevirapine.
But you haven't done that yet?
Yeah, we could, yeah.
Okay.
Yeah. Mm-hmm.
Hi, another question for Jonathan. Thank you for a great presentation. I'm Mike Keegan from ViiV Healthcare and Imperial College London. Yours is a group I've followed for a little while because we work in similar fields and actually have a related question I was going to ask again about ART differences. And in fact, it was our study that was looking at efavirenz switching to dolutegravir, where we saw an increase in kynurenine and kynurenine tryptophan levels in suppressed patients. But we saw a corresponding decline in depression and anxiety scores and sleep quality scores for those patients too. So referring to the previous question, I think that there's probably some competing mechanisms there, and I would ask, given that you've got quite a large cohort there, whether you were able to explore those differences between agents. The key piece there being that there was some mouse data looking at efavirenz and nevirapine potentially inhibiting the IDO enzyme itself. So when you come off those, you may see an increase in kynurenine levels. But was it all just NNRTI as the third agent?
Yeah, about 99% were NNRTI as the third agent. Yeah.
Thank you. Okay. If we go over to microphone 1, please.
Thank you very much. My name is Yasmin from Ghana. My question goes to Hulin. We find in my setting, we have a lot of our patients coming in now with hypertension, and even the young patients, hypertension and dyslipidemia. I wanted to find out, in your cohort of patients, were there any other risk factors for stroke in the patients you selected, apart from HIV itself? Were any of them hypertensive or the abnormal cholesterol levels or diabetic? Thank you very much.
Yeah, this study has some limitations. We did not compare the comorbidities of these groups because our data is limited. We just want to show that the risk of the risk of stroke in HIV/AIDS patients increased among the younger age groups, and I think and the result also revealed that the risk is highest in the first year after diagnosed with HIV and AIDS. Yeah.
Thank you. Hold on. Hi, thank you all for your presentations. They were wonderful. My name is Asante Kamkwalala from the Vanderbilt Center for Cognitive Medicine in the United States. My question is for Farai and Emmanuel. In the children in your studies, did you have any opportunity to evaluate any behavioral measures or look at any of their learning or performance measures as they continue to get older and kind of hit those key developmental stages that may be interfered with by their ART medications or their HIV status?
So what we didn't mention earlier, because we are trying to actually focus it on the neuroimaging study, but the group of children we are looking at, this is a general follow-up study of both neurodevelopmental and neuropsychological measures. So there is a group, a part of this study actually that focuses on looking at the neuropsychological related things that, and then we are, at the moment we are trying also to, when we are done with this neuroimaging study, to correlate this with the neuropsychological parameters. So we are doing that, and the plan is, we've already started it off for 5, 7, and we are doing it at 9 and 11 years. So not just the neuroimaging study, but also the neuropsychological parameters to see if what we are seeing with neuroimaging have got any relationship to their performance in future. Yeah.
Follow up, if I may. Do you plan to follow these children as they continue to age into adolescence and adulthood as they get older?
For now, we are just dealing. We are going to follow these children up until 11. Subsequently, we'll know how, depending on the result that comes out of it, we'll decide if, or that will decide whether the team that is involved would want to go further to follow them up into adolescence and maybe to adulthood.
Thank you.
Yeah.
So just on that same theme, so you have these neuroimaging data, and there are the phenotype or the neuropsychological testing is going alongside. Although they've not been linked yet, could you comment on whether the neuropsychological performance is what you would expect, or are the children with HIV performing more poorly than you would expect? Have there been any reports, descriptions from your data set?
So there was a recent study that was published by one of our one of the key investigators in this study, Barbara. For example, most especially for the interrupted children, it showed the results showed that the interruption didn't have actual effect on neuropsychological measures at age 5 years, while we are seeing quite a lot of differences between interrupted children and the uninterrupted children at age 5. So the concern is that at the moment we are not seeing any neuropsychological related issues on these children, but we want to follow them up for that. And that's what part of the whole neuropsychological study, part of this follow-up study that we are doing. And she and her team is doing that at the moment to see what happens at 9 and 11. Yeah.
Thank you. Go over to number 1.
Yeah, thank you very much. Casper Rox from the Erasmus Medical Center in Rotterdam. I actually have 2 questions for Jonathan. I would like to congratulate all presenters, though. Jonathan, you showed very nicely that there are some inflammation markers associated with depressive symptoms. And I was wondering, why should we measure these or use these measurements in our clinical care over more traditional markers of inflammation like CRP or CD4-CD8 ratio, which are also much wider available? Are your measurements or assays more discriminative?
Question. So as far as CRP goes, that's probably one of the most established biomarker and meta-analyses of biomarkers associated with depression in non-HIV infected patients. We chose these biomarkers basically because it was a secondary analysis, very pragmatically speaking. However, these biomarkers, the kynurenine tryptophan ratio, has very good kind of a priori mechanistic reasons for why it would be associated with depression. So the enzyme IDO1 that catabolizes kynurenine into tryptophan into kynurenine. Also, downstream products of kynurenine include neuropsychiatric toxins such as quinolinic acid, and tryptophan is a precursor for serotonin. So there's some association with serotonin dysregulation and depression as well. And as far as soluble CD14, IL-6, all these kind of pathways have been explored in more of the basics translational sciences. And we see mechanistic pathways associating IL-6 and soluble CD14 and soluble CD14 inducing IDO1 to increase KT ratio. So kind of looking at these biomarkers mechanistically based on a priori literature is the way kind of we set forth in this study. Did I answer your question?
Yeah,
Okay.
you did. I mean, okay. I think you mean that there are also biologically plausible associated with immune activation, that it might be more discriminative, but is that correct?
Yeah, so there's biological plausibility and the previous literature that supports these pathways. No.
Right, and also extrapolating on that, if I'm correctly, you looked at this in the blood compartment. Are there any initiatives to also evaluate this in, for example, the CSF, and also in light of your colleagues who looked at MRI of brain with abnormalities, to combine it with MRI results?
Yeah, that's a great question. So unfortunately, this is a closed cohort. We did not collect CSF, so that's off the table. As far as neuroimaging, again, it's a closed cohort, so that'd be hard and a little bit expensive as well. No.
Thank you very much.
Great question. Mm-hmm.
Sven Schalbach, Novo Clinic, Berlin, Germany. Question goes to Jean. Thank you very much for the analysis, because I think for the very first time you looked into a bit more of symptomatology when it comes to neuropsychiatric symptoms. And what I found very striking was that in those few patients where you actually saw a correlation, that you didn't see preceding insomnia. Because I wonder sometimes if we're just looking for the wrong symptomatology based on the experience we have with efavirenz, where insomnia and nightmares and things, where those things we actually detected. Clinically, I wonder if sometimes, at least what we see, patients who actually respond neuropsychiatric symptoms to dolutegravir more present with kind of impulsiveness, aggression, psychotic symptoms, instead of really the classical depression, anxiety, and insomnia spectrum. I think it would be worth to more look into this kind of symptomatology, and that probably explains what we see, the difference we see between the clinical studies and what we actually see office-based, where patients present in a different way in the studies, just as a remark.
Okay, no, point taken, thank you.
Okay, thank you for all your questions. Any other questions from the audience? So we had one presentation short, so I think we'll close this session a few minutes early. But I'd like to thank you all for coming and for the great questions and engaging, and thank you all for the lovely presentations. Thank you.